So now I have the difficult task to try to summarize this meeting in an algorithm for treatment of neuroendocrine tumors. And I will assume that not everyone will agree with my suggestions. But I will take you through the background and discussion for this suggestion of treatment algorithm. So if we look at what we have today, and if you go to the literature, you have at least 4 different guidelines. I think there are some more. There are UK guidelines and so forth. And we don't know exactly how should we put all these data together into one piece of work that we can rely on and we can use in the clinical practice. So, as I said, a lot of guidelines. How should we use them? And we have some insight in the molecular genetics and tumor biology and biomarkers and classification and molecular imaging at the moment. And what would be a reasonable treatment algorithm? We have to wait for Aldo's data to come out in the future to better define what kind of treatment we should give our patients. Once again, these are the current therapeutic options in neuroendocrine tumors, and I will briefly summarize for you what we have been said during the last day and so on. We have talked about surgery, and we have heard about the curative intent and ablative surgery, debulking by radiofrequency ablation, embolization, chemoembolization, and radioembolization. And then we have discussed in depth a medical treatment, which I come back to, and of course also irradiation, both external and tumor-targeted. Again, as I see the factors influencing the therapeutic decision, the type of neuroendocrine tumors, TNM stage and grade, and also the WHO classification, extent of liver involvement, as was pointed out yesterday, functioning versus non-functioning tumors. We had to control the clinical symptoms in some way in the patients, sometimes very urgent. Patients' performance status, of course, is also very important to take into consideration. And also, of course, the availability of different therapeutic modalities. And I must say that most patients are discussed in a tumor board, at least at our center, and we always discuss the different treatment modalities, and often the patient receive a combination of different procedures. So, short review of the therapeutic advances. Just mention radioembolization, which I know is coming more and more, and using different microspheres. And in Europe, we are using mostly SIR spheres. And here are the results from the largest study with a PR and complete remission of about 62%. This is an effective debulking procedure. It's not curing the patient, and it's also a cumbersome procedure, both for the patient and for the doctors. And it's also a very expensive mode of treatment. We have the targeted radioactive treatment, which was covered yesterday. And we have some data from our centers in about 230 patients. Today it's 250, with CR and PR and minor responses in 43%. And similar data from the Rotterdam experience, and that is not surprising because we have been using the same protocol, except that we are doing dosimetry. And here are the data on overall survival and time to progression. As I showed you yesterday, and higher uptake on octreoscan is giving the better outcome and also a better performance status. Cytotoxic treatment were mentioned during this meeting, and I just want to point out that the best data so far is the recent data from, or not so recent, but during 2000 at least, in pancreatic NETs by the group at MD Anderson, showing objective response of 39% and a median survival of 40 months. If we look at carcinoid tumors, it's quite clear that the response to cytotoxic treatment is significantly worse and shorter median survival. And as I pointed out yesterday, at least in my experience, sometimes we may be shorten the survival for some of the patients with carcinoid tumors. I'm now talking about the low proliferating carcinoid tumors. We have also the data on poorly differentiated tumors with cisplatin etoposide showing some encouraging objective responses, but again, no randomized trials and also a limited number of patients. Temozolomide has increased in interest over the last 4 or 5 years, and it is an active drug in particular pancreatic NETs. And here we have a summary of different trials. And so if you look at these data, they range from 14% up to 70% objective responses. All of them are phase 2 or retrospective studies, and with, again, a rather limited number of patients. So here we need more data. We need a randomized trial comparing temozolomide with the so-called standard of care, such as cisplatin etoposide in grade 3 tumors, or streptozotocin 5-FU in grade 2 tumors. This was the data on temozolomide and combinations with capecitabine, bevacizumab, and again, I want to point out the interest to analyze more in detail the MGMT expression, if we can use that as a predictive marker to use temozolomide. For everyone knows that has been working with temozolomide, it's quite expensive. So if you combine temozolomide with capecitabine and sometimes also bevacizumab, you can end up with 10,000 euros a month easily for a patient's treatment. So you would like to know if it's a cost benefit. And this I showed you yesterday, that there's a difference between pancreatic NETs and traditional carcinoid tumors. The pancreatic NETs has significantly lower expression of MGMT compared to the carcinoid tumors. And this is the Strasberg recently published retrospective study, which has, of course, to be confirmed in a randomized trial. So we had also yesterday discussed the PROMID data, which is well known to all of you, that in a phase 3 study for the first time we have confirmed what we have known for many, many years, that you have an anti-proliferative effect of somatostatin analog. And in this study, it was also noticed that there were no difference between functioning and non-functioning tumors, which clearly changed the guidelines both in US and in Europe, and that the patients with lower tumor load might benefit better than those with high tumor load. Of course, that should be confirmed in future studies. Also the information about resected primary. If you have a resected primary, you also had a better outcome. Angiogenesis have been discussed in detail last day, and also we have been discussing the rationale for combining everolimus with octreotide LAR. It has been said several times. Just to give you the different RADIANT studies, RADIANT 1 study showing that you might have an increased benefit, so-called clinical benefit, if you combine everolimus with octreotide. And that is shown in this slide. If we look at PFS by central radiology review, there seems also to be a difference between the combination of everolimus plus octreotide versus everolimus. An interesting observation in this trial was that if you look at the response in chromogranin A, circulating chromogranin A, if you had an early response, you had a significantly longer PFS. So maybe here we have also a marker of early response and also a prognostic marker for treatment with everolimus plus octreotide. We have the RADIANT 3 data showing a benefit in patients with progressive pancreatic NETs, everolimus, PFS of 11 months versus placebo 4.6 months. And we have the RADIANT 2 study, which gave us some headache because we didn't meet the endpoint that we had decided in advance. So we just missed it by central review. But as you heard by Dr. Yao last day, that when we look at the investigator review, local investigator review, we get a significant difference between the two arms. And I think this is something that we had to analyze in the future. Should we have central review or should we have a local review? In my view, and that's my personal view, is that the local investigator knows the patient best, and he can judge when there is a progression. And another problem with the central review is that you are not analyzing the same lesions as they are doing in the local review. We have also discussed yesterday sunitinib, and this was a study also in pancreatic NETs. The other RADIANT 2 study was done in carcinoid tumors, patients that had presented carcinoid syndrome in some way, including both the lung and the midgut carcinoids, and also some other odd so-called carcinoids, head neck carcinoids and so on, which I don't know exactly what we should call them. Maybe it was paragangliomas. So that also had some impact on the results in that study. If we look at the sunitinib data, it's almost a blueprint of the results of the RADIANT 3 data in pancreatic NETs. So that was a short summary of what we presented last day. And based on this, we had to discuss a treatment algorithm. And this is my personal algorithm. And it's based on the WHO classification with G1, G2, and G3 tumors. We have been using it actually for many years at our centers. I can just remind you that we introduced already in 1989 Ki67 as a marker, but no one did take any notice of it. But now it's established both in US and Europe. So we don't have all the fancy data that Aldo will come up with. So we can't subdivide our patients better. But Ki-67 has been shown to be quite a good market to use. It summarized in some way the tumor biology, and that was brought up by Günther Klöppel and also by Aldo in their presentations. We have been using the WHO cutoff levels, and if we start with the easy part of it, if we start with the G3 tumors, the poorly differentiated tumors with high Ki-67, about 20%. I think the first line option is still cisplatin plus etoposide, but they had to compete with temozolomide plus capecitabine, and in some extreme cases, I have seen patients with Ki-67 of 95%. Those patients can benefit from adding bevacizumab as well, so you have a triple combination. If we then go to the other end, the WHO G1 tumors with Ki-67 less than 2%, I think that is mostly classical mid-gut carcinoma tumors. Most of these tumors are usually less than 1% proliferating cells. And somatostatin analog, I think, must still be considered as first-line treatment. Of course, there are options. Alpha interferon has been used a lot in Europe. Everolimus, we have the data there. And sunitinib is only for the PNETs. There are no trials indicating a value so far in small intestinal tumors. Concerning everolimus, how should we use it? As I see it, when you have a patient that are progressing on somatostatin analog, we might add everolimus, or we might add alpha interferon. In my own practice, I have seen significant benefit of combining somatostatin analog with everolimus in patients with classical mid-gut carcinoids that are starting to progress. Usually, if you take a new biopsy, you can see that the Ki-67 started to rise, indicating that you have higher sensitivity for the drug. Second-line treatment, I just told you about somatostatin everolimus. And the third-line treatment, I have indicated PRRT. If you go to other centers, they might put PRRT up front as maybe first-line treatment. But this is how I look at PRRT, because we had to learn more about it. We don't know the long-term side effects. We don't know the long-term, because some of the patients have already started to develop blood malignancies and things like that after treatment with radioactive compounds. We also had to define the protocol in a better way. Now we are standardized, giving 3 or 4 courses, and then we wait and see. Maybe we should give 1 course, wait, and then until progression, we give the next course. We don't know, and there are no randomized trials. So therefore, I think it's appropriate to put it as second or third line treatment. As you can see from my algorithm, I have not put PRRT on the grade 3 tumors. And our experience is that highly proliferating tumors usually have low expression of somatostatin receptors, and they are not susceptible to treatment with PRRT. So it's a waste of money. Then we have the problematic group in the middle, the G2 tumors. In Europe, streptozotocin 5-FU and doxorubicin had been a standard of care, although the drug has never been approved by any organization, not EMA or FDA or whatever, but it has been a standard of care. And I know that many centers also in U.S. use the combination of streptozotocin, 5-FU, and doxorubicin. But here, I think there will be a very strong competition with the new drugs, with everolimus and sunitinib, particularly for the pancreatic NETs. So I foresee that many of you medical oncologists in the audience will change from streptozotocin plus 5-FU to everolimus and sunitinib or sunitinib as a first-line option. Of course, what is needed in the future is, of course, a head-to-head comparison between the standard cytotoxic, the standard, so to say, cytotoxic treatment, streptozotocin plus 5-FU, and the new drugs. Because now we have the data comparing placebo, but we have not compared with the standard cytotoxic regimen. As second-line treatment, I have put up temozolomide plus capecitabine, and again, we had to look more carefully into that. And we have also proposed within ENETS that we should do some randomized trials comparing temozolomide with streptozotocin in this G2 group of tumors. So far, we have difficulties with the funding. Third-line treatment or second-line treatment in some centers might be PRRT. We know that this group of patients, they express somatostatin receptors in rather high number, and therefore they might be sensitive to treatment with PRRT. So that is about how I see this treatment algorithm in metastatic NET. And as you can see, it's not divided into pancreatic or small intestinal or colorectal or so. I think it's based on the WHO and ENET's classification system. I have always put surgery on top, and I think that makes Massimo happy and some other surgeons. And I think even if Massimo showed that only 9 to 10% can be downstage of the tumor, I think it's appropriate when you're working in a tumor board that even if you have started on medical treatment, you should discuss the patient forthcoming in the tumor board, and sometimes surgeons might be able, maybe not to cure the patient, but resect more tumor during after the treatment, medical treatment. And also in this setting, also embolization and other debulking procedures. We discussed in the cases yesterday that if you have confined all the tumor lesions confined to the liver, visible lesions, you can, of course, whenever during the course of the disease, during the medical treatment, you can always add embolization, even radioembolization. So to conclude, for the first time, we have 4 large randomized placebo-controlled studies, including more than 1,000 patients. And I think that is something that we had to be proud of, because we have been far behind comparing to other malignant diseases. So we can now start to base our treatment. It will be more evidence-based medicine we are working on. It's not eminence-based medicine. Will the new agents replace current standards of care? I had a discussion with you just now, and I think that there will be some changes for pancreatic NETs, definitely, and we'll see what that will give us in the long run. What will be the prerequisite for change of treatment? It's easy to give a tablet to the patient instead of taking him back every 3 to 4 weeks to give him an infusion of streptozotocin 5-FU. But of course, we had to consider other things that we had to look at. Overall survival, is the PFS translated into an overall survival? It takes some time to learn about that. Quality of life. What has been missing in the Radiant-2 and Radiant-3 trial is that we didn't have any quality of life assessment, which I am really regretting, because I think that is something that we have started to ask more and more. In the sunitinib study, they had a quality of life evaluation, and they claim, when you look at the figures, that the patients were doing as good as well as in the placebo group. And of course, we had to take cost into consideration. And also personalized treatment based on tumor biology and molecular genetics will come more and more, and I will be eager to see Aldo's data in the future and see if we can subdivide our patients that are in grade 1, grade 2, and grade 3 tumors into subgroups. So for the time being, until we have all these fancy new data, we had to explore the WHO and TNM classification system for improving our treatment. We had to look more and more into personalized treatment based on the tumor biology we know at the moment, such as Ki67 and other markers that has been discussed. And something that has not been brought up, but that is areas where some of us are working in, trying to come into a completely different treatment modalities, such as oncolytic viruses. We have such a virus, an adenovirus, where we couple the chromogranin A promoter to the adenovirus to target it to metastases of neuroendocrine tumors. We are working on nanoparticles covered by somatostatin analogs, which can be targeted directly to the tumor tissue. So that is something that might come in the future. So I stop there and thank you for your attention.